Good evening. I think we're on. It's wonderful to see everyone this evening. We're so pleased that you've been able to make it to our vaccine town hall. We're delighted that it seems we're going to have the biggest group of collection of people that we've ever had on a town hall tonight, and that makes us very happy. I'm Sharon Davis-Murdoch. I'm the co-president of the Health Association of African Canadians, and we are so pleased to have you all, as I've said. This is going to be one of our vaccine town halls, the first one. I don't know, we may have others as time goes on. We're expecting to in possibly in February and or March. And we are going to be really focusing tonight, the aim of the town hall tonight is to address concerns related to mistrust in the vaccine, the response by government and public health, and the healthcare system overall. Those are the things that we're going to be talking about this evening. And before I hand it over to my co-president and co-host, my dear friend Veronica, I'm going to just say to you that because we have so many of you online tonight, we would ask that you hold your questions. You can maybe put them in the chat, but we won't get to the questions until the presentations have been completed. It is possible that we won't get to all of your questions at all, but not to worry, because you can write your questions in to the HAAC website, and we will provide answers on the HAAC website after the town hall. So one way or the other, we will be responding to you. But I do ask for you to put your questions in the chat and to wait until the end of the presentations before you will hear us address any of the questions. So over to you, Co.
Thank you, Sharon, and good evening, everyone. Thank you so much for joining us. As Sharon has stated, this is probably the first of a couple of more town halls that we'll have on this subject. Trusting you all have been staying as safe as possible through this pandemic. And so this evening, we are going to have three speakers. We're going to have Dr. David Haase, we're going to have Dr. Gaynor, and we're going to have Dr. Jacob Cookey. So as has already been indicated, we'll have those guys speak to us, provide us with some information that you can ponder about, consider, and then at the evening, so that'll run for about an hour, and then at the end of that, we'll have our question and answer period. So at this particular time, we're going to turn it over to Dr. David Haase, who will introduce himself and speak about the history of health issues in the African diaspora and the issue of trust and vaccine hesitancy.
All right, good evening, everyone. So I'm David Haase, retired infectious diseases physician, internal medicine. And before we kind of get ourselves moving, I'm going to do something a little bit different here. We're wanting to find out about you, a little bit about you. Can you all see the screen? Yeah, okay. So here's what you need to do. At the top of the slide, you'll see a website. Get out your smartphones or open another tab on your laptop or, you know, your computer, if you like, and go to www.menti.com. When you get there, you'll see a blank sort of box. Put in the code 275086. Give you a few minutes to do that. And what's going to happen is you're going to see questions on the screen, which you can answer on your smartphone. And you're going to answer and then hit submit, and then we'll see what we see. Alrighty, we'll give you, I'll probably give you about a minute initially to answer the questions because you need to get accustomed to the system. So we're going to go. Alrighty, so I'm going to open the polling. So here's the first question. Where are you geographically located right now? So just put in where you are and then submit. And we'll see where you all are. And the larger the letters, and the size of the letters, are the more people in that area. So I should have started the timer. Sorry, we'll start the timer as well. Give you about a minute. Make sure everybody has a chance to put in their answer. Just interesting to see where everybody is. Wow, somebody in Nigeria, man. Okay. All right, few more seconds left. Get your vote in there, get your word in there. All right, we're going to close our voting then, and we're going to move to the next question. So here's the next question. What do you regard as your racial identity? Now remember, these are anonymous. We're not going to know who has put in what. So you can go ahead once I open that and put in your vote. Start the timer. And we'll see. Few more seconds left, and then we're going to be done with that. All right, we're done. Let's move on to the next one. Just a few of them. What is your age range? And you see on your screen the age ranges. Just select one and then go submit. Again, we don't know who is who, so put in anything you like. Ah, I didn't open the voting, did I? And there's our timer. I'm going to close this one early. And let's move on to our next. And here's the last one. How do you describe your gender identity? All right, I'm gonna close this as well. So just a little bit of a start. Let's move on then to look at why we're here. And maybe before we do that, Carla, can you just mute everybody, please? And
It muted you as well, David. Unmute.
okay, can you hear me there? Yeah. Okay. Carla, can you hear me?
I can, sir. Yep.
Okay. So COVID-19 came calling, and we know COVID-19 affected our Black community in a way that was not very pleasant. And then we had to do all kinds of things, and now along comes a vaccine. And so now we're being asked as a Black community to accept this vaccine and to roll up our sleeves and get this vaccine when our time comes. But let's talk about two words that come into play with this vaccine. One of them is trust. And what does trust mean? The definition you see there: a firm belief in reliability, truth, ability, honesty, integrity, or strength of someone or something. So that's trust. And then we have the other word, which is a bigger word, mistrust. And it's being suspicious. You have no confidence and you doubt. So we're being asked to trust that this COVID vaccine is a good thing for us. And as we see here, many people in North America, the Black Americans, and here we know, even in Canada, that many of us are mistrustful for lots of different reasons. You know, we're worried about being guinea pigs, we're worried about the harm this vaccine could cause, et cetera, et cetera, many reasons. But we do have good grounds to be mistrustful of the medical system, the government, and the vaccine itself, because we have a history of being mistreated. We have a history of experimentation and exploitation. And so we remember the history. It's a collective memory. And we'll talk about present day times as we go along. The Tuskegee syphilis study is the one that most people seem to recall. And that comes up over and over again when people are talking about why we mistrust the medical system. But in fact, that's only one of many instances where there was, misuse of Black people in the medical system and in healthcare. Going back really to the time of slavery, when Black people were brought forcibly to North America. And if you we have not got the time to go through these things, but there were many instances really when the enslaved people were used for medical experiments, surgical experiments, many of them with adverse health outcomes and even death in some instances. So it's going back even a long way before Tuskegee and even after Tuskegee and coming up to the present day. I don't know how many people have heard of HeLa cells. Henrietta Lacks was a Black woman who you see her lifespan. In 1950, she had cervical cancer. Cancer cells were taken from her cancer without her knowledge, without her permission. And her cancer cells are actually immortal. They had tried to grow cells in the lab before, but failed, and her cancer cells have been reproducing themselves in the lab, since 1950, and have really been one of the great scientific advancements because they've been used for infections, to study infections, to study different conditions, really have made a huge difference. But the point is, she had no knowledge this was going to be happening. And even her children were misused in
You're on mute, David.
Okay, hearing me again?
Yep, all's good.
All right. Okay. So, this is again another example of the sort of misuse and abuse. It's medical racism, if you will, and it still goes on this day. And now my slides are not changing. Okay. Okay, there we go. If you get hold of this book called Medical Apartheid, this was written in 2007, updated in 2008. It goes through that history up to that time where there was a lot of experimentation and exploitation of Black Americans. And these are more recent examples of racial differences in the way we're treated in the medical system. I'm going to go through these very quickly. There's an article that was published from an American author, two authors, where Black babies were likely to survive better if they had Black doctors, and again related to the issue of racial bias. More recently in Toronto, this is about the treatment, the screening of Black women for breast and cervical cancer, and again, lack of health data, which is something we've been talking about. And even in New York, there was a Black doctor who died of COVID-19 after complaining. She was sent to a different, she was discharged, had to go to a different hospital, and then she died. And then a shout out to Dr. Dryden and Dr. Norum, who talked about anti-Black racism in medicine. So we're asked to go from mistrust to trust. And how do we do that? Well, there are two Black women who are leading the way, and I just want to give you a brief snapshot about them. Here's one, Dr. Kizmekia Corbett, Kizzy, who is a research scientist at the NIH in the US, National Institute of Health, and a vaccine immunologist, has been instrumental in developing the Moderna vaccine, the mRNA sort of technique and that new vaccine. Here she is, another shot again. And then here's the other woman that I want to give a shout out to, Sandra Lindsay, who was the first person in the US to take the COVID vaccine. And I'm going to just show you a quick video here of her taking that vaccine. She's an ICU nurse and decided that she's going to step up and be the first to be injected with this vaccine. Here the camera is going off in the background there. So those are two Black women who have been leading the way. Sorry, that wasn't supposed to come on here. Technology always goes. Sorry about that. Let me. Sorry about that. always works when you try to do stuff. Let's just go back. Here's another short video as well about Kamala Harris, who we know is of African descent, getting her vaccine.
So our first sanitize your arm, and then I will administer the vaccine.
Okay, got it. How are you doing today?
I'm doing well.
You've been busy, huh?
Yes, ma'am.
It's good to be here at United Medical Center. You guys do such good work here.
Thank you.
Okay, let's do it.
All righty.
Ready? Yeah, I'm ready. That was easy. Thank you.
There's no bleeding.
I barely felt it.
Oh, really?
I barely felt it.
Awesome. I will just apply that.
Yeah?
Wonderful.
So in the interest of time, we'll move on. You know, so that's all well and good. These two women you saw taking the vaccine are from the US, but I want you to meet Lisa. I'm going to hand over to Lisa to tell you her story. And Lisa, you're there. Yep. Go ahead.
Need to unmute, Lisa. Nope.
Can you hear me now?
Yeah, we can hear you. Go ahead.
Hi, I'm Lisa Colley, and I work at Northwood, and I received my vaccine. Actually, I have both doses, and the vaccine that I have that I received is the I think it's the FEMA, and at first, I was quite nervous. I had a little bit of anxiety. I wasn't sure if I should take it, especially hearing all of the different negative things about the vaccine. And once I got my phone call from my employer asking me, did I want to take the vaccine? Initially, I said no, I didn't want to. And so my manager, she said, okay, you know, we're hearing a lot of that, so it's totally up to you. We hung up and I sat down and I thought about it. And I said, you know, I weighed the pros and the cons and realized that I have a lot. Um, I should take this. I was really afraid not to take it because I have a granddaughter who has cystic fibrosis, and that disease is a lung disease. And if she contracted the coronavirus, it could be deadly. So I thought, you know what, I have to weigh my pros and cons, and I decided to take it. I called my manager and I told her I was considering taking this, and I did. Um, I got a phone call and an email. I think it was around the 12th the 12th of December. And on the 16th, I received my first dose. Once I received the dose, I would say about 3 days later, I started to feel chilly, like I was coming down with something. And but then it subsided. And on January the 6th, I received my second dose. And I received, I had no symptoms whatsoever, no side effects. And I just want to encourage everyone to take it. You know, we come from a close-knit community. I'm from North Preston, and I reside in Cherrybrook. And, you know we mistrust the healthcare, and we have every right to, but we want to get back to normal. We want our lives to, you know, just to come back to the way it used to be. We're people that like to go to church. Our weddings are huge. And it's been a big impact in the Black community, especially the Preston community, because not only is it affecting us emotionally, socially, physically, it's also is affecting us. And I'm hoping that everyone out there that's listening, hear me, see me, that they consider once it is available to the community, that they will take the chance, take it. We have nothing to lose. We have more to gain. So I'm just hoping that everyone will consider taking this. That's my story.
Thank you so much, Lisa. Thank you, thank you, thank you. Really appreciate you you coming on and giving us your story. So we're going to move on now to Dr. Gaynor Watson Creed, who is going to be presenting.
Hi, everybody. Can you hear me okay? Okay,
Yes.
great. Good to see you all. Lovely to see so many familiar faces back here. And 80 people on this call already. That has got to be a record. So fantastic. And hats off to you, Miss Lisa, for sharing your story as often as you have. I heard you on the radio on Thursday, and just fantastic to have a champion like you here with us tonight. So I'm going to share my screen, and I'm going to actually take you mostly through the ins and outs of the vaccine itself. And so David opened by talking about trust and mistrust, and I think what I'm going to share with you is why I trust this vaccine, why I am so pleased that my own mother, who I think is 82, but don't quote me on that, and in a long-term care facility in Charlottetown, got her first dose last week. And why I'm looking forward to getting my own family vaccinated. So nobody pays me to do this work on behalf of the vaccine company, so I don't have anything to gain there. But I think I share some of the concerns that you share in terms of protecting Black communities, and also making sure that we get to go back to a life where we can be with each other once again. So I'll basically jump off from where I left you last time. For those of you that were in the call in the fall, we'll talk just a little bit about where we're at in the outbreak right now, but then get into what is it about this vaccine, and then some bottom lines. And Dr. Cookey's going to go after me, and then hopefully we'll get to some questions. So some of you might remember this. Do you remember when we were talking about this outbreak last spring, and the Public Health Agency was predicting that if we're lucky, and if we can hold the line with our public health measures, we might end up in a place where we'll have the big wave in the spring, but then hopefully we can keep it to little waves between now and when we get the vaccine. And we weren't sure when the vaccine was going to be then. Anybody remember that from last spring? So that's what we hoped would happen. This is what actually happened. So here's the Canadian picture as of January 8th. You'll see that first wave in the spring down here on the left-hand side of your screen. And then over the summer, we did not bad, but getting into the fall, more indoor activity, and most importantly, more things open in more provinces. You see this steep upward climb now in Canada with not really any signs of slowing down anytime soon. It's unfortunate because it means that that pressure from the Western provinces, particularly Quebec and Ontario, is constantly kind of banging against the wall of Nova Scotia or against the wall of what was the Atlantic bubble. And so that's what we have to continue to look out for. But there is some good news. So this is the national picture. You can see the doses, the cases as of today, approaching 700,000 cases in this country, which is just incredible when you think back to where we started. But here in Nova Scotia, the things that we put in place last spring and that we've largely maintained are working. So that picture from the Public Health Agency from the beginning, where they said maybe we'll have a big wave and then we'll have, sort of a few little waves in between. So far, that's what we've gotten to in Nova Scotia. We had a nice long stretch during the summer where really we kept our activity very low. The fall, with more things being open again in Nova Scotia as they were, now schools are open. We reopened our hockey rinks and our fitness facilities, all of those types of things, and came inside more. We did see that second wave. We've come down out of the second wave. We're not out of it yet. We still see flare-ups of cases happening across the province, but it's certainly trending in the right direction. So that's the good news. Just a little bit more detail on the second wave here, but I won't spend any time on that. So here's the bottom line. The things that we did worked. We need to keep doing them. So, the social distancing and the mask use, huge impact on our outbreak so far. The hand washing, limiting our indoor activities, keeping our gathering sizes small again has had a huge impact. Keeping to cohorts of consistent groups of people, as difficult as that is. And of course, avoiding crowded spaces. All of that is still happening in Nova Scotia, and it's part of why we're actually, despite all of those restrictions, one of the most open provinces in the country. So we're not having to face the big lockdowns, for example, that Ontario and Quebec are imposing as of this. So that's the first bit of good news. And then the second bit of good news is that when I spoke to you in the fall, I had said, we know the vaccine is coming. Here's what we think it will look like at that time. This is what we were thinking, that we would get very, very tiny amounts in the first few allotments, and logistic challenges would be huge, and that we would work with our national partners to get some consistency on some things, for example, like prioritization. And the National Advisory Committee on Immunizations was already working behind the scenes. They've been well at it for several months on getting the necessary statements to support why we need to do what we need to do with the vaccine out and rolling. And now those vaccines are here. So I'm just going to state for the record that from my perspective as a public health physician, immunizations are the second most powerful preventive medicine that is available to public health. They are incredibly valuable. And we used to joke in public health that if we had a vaccine for cancer, we would use it because they are so effective with such a beautiful side effect profile. And then we did have a vaccine for cancer. We were able to develop one in the form of human papilloma virus, which is a vaccine against cervical cancer that David mentioned before. So the COVID vaccines were created in a climate where we already knew a lot about vaccines and what we need to look for as we're developing vaccines. And I'm not going to spend a lot of time on going through the types of vaccines that preceded the coronavirus vaccines, except to say that there were many. So you will have heard of talk about live attenuated vaccines. These are the vaccines where we actually carry whole virus or close to whole virus, but it's attenuated, so it's not actually able to replicate into the virus and into the body, and the body reacts to that, and that's what gives you the immune response that protects you later on. Then you can have inactivated vaccines that will carry fully inactivated virus or parts of the virus into the body, and that's what will trigger the immune system. And then you have these other vaccines that carry much smaller portions of the virus into the body to carry, or bacteria in some cases, to create that immune response. And so what you get from any of those is the generation of what we call antibodies, which is the immune protector in the body that will react now. It will remember and react anytime it sees something that looks like those viruses or bacteria in the future. That's the idea behind vaccines. This particular vaccine doesn't quite work like the ones we've used before, but it's a technique that scientists have been trying to refine since the 1980s. And so this one, the two vaccines that we have right now, the Pfizer-BioNTech vaccine and the Moderna that have been licensed in Canada, use a mechanism of action called messenger RNA or mRNA, and David mentioned this earlier. The idea here is that they're not using any whole virus at all, so you can't get COVID from the vaccine. What they do is they take basically the secret code from the virus in the form of RNA, which is basically it's a coding protein that all cells have. They take the virus RNA and they introduce that to the body just enough that it triggers your body to turn on its own mechanism for producing something that looks like the virus antigen. It's not the virus antigen, you can't get sick from it, but it looks enough like it and your own body has made it. That your immune system reacts to it, learns to recognize it. And so now when it sees the real deal in the form of the virus, it will respond to that and mount the immune response that protects you. The RNA that gets introduced to the body is actually modified so that it doesn't cause the body to react strongly to it. That was a big part of the work they needed to do in order to get mRNA vaccines to work properly, was to modify the RNA so that it didn't trigger a huge response. And so that's the technique that they've been working on. That Dr. Kizzy, that David mentioned before, has been so instrumental in moving forward to get these vaccines on the market. This is actually a faster mechanism for producing vaccines than the normal mechanisms we might use, for example, to produce a flu vaccine. And that's part of the reason why these two vaccines came to the market first. The way the vaccines come to the market under normal times is that we would do a number of trials or experiments. First, sort of looking at lab data around the vaccine. So without introducing any kind of living recipients of the vaccine, either animal or human, look at the lab data around the vaccine and see if it seems like it's the type of thing that would work in those living hosts. Then we would move it to animal trials, and then we would finally move it to human trials. And then after that, we put it into the market. And even then, we're watching what happens as it goes into the market. We call those post-clinical trials, where basically as it rolls out into people in real life scenarios, we're still gathering all the data on the vaccine to see if what we thought would happen is actually happening, and to course correct if we need to, if the vaccine isn't doing what we thought it would do. And so the same processes happen for these vaccines despite the speed that they came forward. And I have to admit, if you asked me, and some of you probably did last summer, if I thought we would have vaccines by January 2021, I think I would have said no. And here we are, and it wasn't just January, we had them in February, which I think is remarkable. But part of what happened is that because of the situation we're in, I think the whole world agreed to a few things that meant that we didn't skip any steps, but we didn't stand for the slowness of the process that we normally use when we're not in an emergency. So we used all of the same steps that we would use to create and approve a vaccine this time around. But instead of waiting weeks and weeks and months, for example, for the vaccine manufacturers to bring the data forward to governments, and then governments take months and months and months to approve that, the agreements up front were that the vaccine manufacturers would give that data over basically as soon as it was created. There was no waiting. And so all of a sudden those timelines got super compressed, which I think is interesting. And I do wonder if actually it's teaching us something about how we might be more effective and efficient at the production of vaccines in the future, so that we're not having those lag times that I think we're questioning, where they really needed to begin with. So that's what happened in this case. And so now we have all of this data that has been produced by the companies that we're able to see around how they did that. And this is where my confidence in the vaccines starts to increase. So the vaccines, the two vaccines we have, the Pfizer-BioNTech and the Moderna vaccine, were trialed on thousands of people worldwide, and they were looking for two things. Of course, they're looking for side effects of the vaccine, so we want to know that the vaccine is safe. And the results, is it actually effective? Is it preventing people from getting COVID? So I'm going to go through that with you in the next few slides. On this slide, you'll see that I've highlighted a few things here. Not only did both companies commit to trialing the vaccine in thousands of people, so the Pfizer-BioNTech vaccine, nearly 40,000 people worldwide were enrolled in that trial. the Moderna was closer to 30,000. They also were deliberate and transparent about recruiting from a number of ethnic or racial backgrounds. And so I've only put a few of the categories here, but I wanted to highlight that Black people were fully involved in these vaccine trials at rates that are representative of the population generally in the countries where the vaccine was trialed. And they were treated in exactly the same way that other participants in the trial were treated. This is really important, I think, to us as Black people to know that we're not being given something that we weren't thought about in as it rolls out. And so that data is there. The companies have been transparent about sharing it. And I was quite pleased when I reviewed the data to see that the rates of participation in Black communities was so high. They also included people who had comorbidities, so other health conditions, which is important as many of us do have other health conditions, and we want to know that that's not going to be a problem when we get this vaccine. They, in both sets, excluded young people, mostly because in order to trial a vaccine on young people, you do need to have a sort of a higher standard around safety, and that would have taken more time than I think, the manufacturers thought was warranted for this particular point in time. Going forward, both manufacturers, I would be surprised if they didn't go back now that we've got some vaccine on the market and look at children and including children in those studies so that they can get that data out and make the vaccine available to children, but currently it's not. Similarly, they didn't include breastfeeding women, people with immunosuppression conditions, and people with autoimmune conditions. Again, just because if there was to be a problem, those could be the areas where we would see them. And in the interest of supporting getting the vaccine out to those people who we know it's safe for, those sort of populations that didn't include these groups went first. I think they will go back now and look at these other populations to see the safety profile in those groups. So here's the results. Both vaccines performed incredibly well after both the first and the second dose. Better, I think, than we see from some of the vaccines that we use regularly, for example, for childhood immunizations. The Pfizer-BioNTech vaccine, the efficacy after the first dose, sort of immediately after the vaccine, it was 52% effective, which is not great, but by 14 days, it was up to 92.3%. And we always say for any vaccine, folks will remember this for flu vaccine, that it takes some period of time for the body to do the work that it needs to do after you get the vaccine before you're protected. So we saw that high rate of protection kicking in at about 14 days for both the Moderna and the Pfizer vaccine, 92.1% for the Moderna vaccine after 14 days. And then the efficacy after the second dose was 95% for the Pfizer vaccine and 94% for the Moderna overall. And here's what's interesting, again, different from flu vaccines, where you may have heard us talk before about the fact that we worry that in influenza vaccines, the immune response in the elderly may not be great if they're over 65, just because the capacity for the body to mount an immune response drops with age. We're not seeing that yet with these two vaccines. So the efficacy after the second dose in over 65 for the Pfizer vaccine was quite high, almost 95%, a little bit lower in the Moderna vaccine, 86.4%, but still quite high. This is good news in terms of being able to protect the most vulnerable with this vaccine. And so I'm certainly happy to see that as well. So that was the efficacy of the vaccine. What we'll be looking for going forward is whether or not that effectiveness holds in real life as we now sort of roll this out in sort of not study conditions. The other thing, of course, that the companies were looking at was for adverse events or safety events, reactions after the vaccine. And so I want to point you to a few things here. I'm just going to see if I can move this. Okay, great. Okay. So I'm going to point you to a few things here. So first of all, I want you to pay attention to which vaccine it is. So the Pfizer versus the Moderna, whether or not we're talking about vaccine or placebo, which is the comparison arm that they use in these trials. And the placebo is basically an equivalent of sort of normal saline, which is a very benign compound that we use in medicine all the time. And the idea is that you don't, when you're doing these trials, you want to know for sure that that the vaccine is what people are responding to. You actually have some people who get the vaccine, but some people who don't get the vaccine. They think they got the vaccine, but they actually got the placebo. And then you compare between the two groups afterwards. And so I want you to pay attention to what happened in the vaccine arms in particular, and also pay attention to whether it happened after the first dose or whether it happened after the second dose, because there was a difference, a little bit of a difference in the reaction profile between dose 1 and dose 2. So when you look at it, what you see is, and this is from the National Advisory Committee on Immunizations, they've just put out their most up-to-date advice for Canadians on these vaccines. And so what you see is that for both the Pfizer and the Moderna vaccine, everybody, whether they got actual vaccine or placebo, had pain at the injection site. That's not surprising because getting an injection hurts. So that's what happened there. Everybody had fatigue. So that's probably not related to the vaccine either. Everybody had headache. So that's probably not related to the vaccine either. If you take those out, then you're left with this list of adverse events from the vaccines. And you'll note that most people experienced more adverse events after dose 2 than they did after dose 1. After dose 1, for both the Pfizer vaccine and the Moderna vaccine, some swelling at the site of injection is common, and we see that with a lot of vaccines. So, that's to be expected. You also see muscle pain, more in the Pfizer vaccine than in the Moderna vaccine. Folks complained of that. That was considered to be very common, which means that it would have happened in more than 10% of people who got the vaccine. A lot of people reporting chills after both dose 1 and dose 2, and I think Lisa, sort of gave us her own version of that with her story today. That's very common after the vaccine. Joint pain, particularly after dose 2 for the Pfizer vaccine, fever, particularly after dose 2 for the Pfizer vaccine, and even nausea and vomiting with the Pfizer vaccine and the Moderna vaccine as well. So those things were common. The other thing that stands out is if you look over at the Moderna vaccine on the right, lymphadenopathy is that sense of swollen glands that you might get if you have a cold coming on, that type of thing. It wasn't actually looked for in the Pfizer trials, but they did note that it came up even though they weren't looking for it. They weren't asking people for it, but they were reporting it anyway. Moderna did look for it and did see that as very common. So that's another thing. So the overall profile you get is that folks tend to get a little flu-like. They feel a little flu-y after they get the vaccine. And then, as Lisa pointed out, within 48, 72 hours, those symptoms resolve and folks are back to themselves. And now they're protected as well. There has been some talk that you may have seen in the media about allergy to components of the vaccine. And that's something we're always looking out for, both in our clinics when we're giving the vaccine, as well as in the period after that. And the sort of initial reports suggested that the allergy was could be to an ingredient called polyethylene glycol, or PEG. This is a compound that's used in bowel preparations. If any of you have had maybe the misfortune of having to go for a bowel preparation for a colonoscopy or something like that, PEG might be the compound that they gave you to help prepare your bowel for that procedure. Laxative contact lens solution has it, cough syrups. There are all kinds of ways that PEG is used. And so that is something that when folks come forward and we talk to them about, whether or not they have any reason to not get the vaccine, an allergy to PEG would be one. But so far, that's it. That's what's being described by the National Advisory Committee on Immunizations as the, sort of the absolute contraindication or reason to not get the vaccine is if you have that specific allergy. Other than that, we're saying that it's worth having a risk-benefit discussion about getting the vaccine. So I've already said that the vaccine wasn't studied in pregnant or breastfeeding women, those with immunocompromised or those with autoimmune disorders. But even then, nationally, our sense is that there's no good scientific reasons why we need to be highly concerned about those groups getting this vaccine because of the way the vaccine works. And so with that in mind, what's being suggested and what the National Advisory Committee on Immunizations has endorsed, and I think this makes a lot of sense, is to have a risk-benefit discussion with the person. Is your risk more from getting this vaccine, or is your risk more from getting COVID? And if the answer is your risk is more from getting COVID because of the disease you have, then you should probably get the vaccine. And so that discussion is being offered even now as we're rolling the vaccine out in Nova Scotia in healthcare workers, for example, in long-term care facilities. That is some of the conversation that folks are being invited into with their specialist physician, if they have one, with their family doctor, or at the vaccine clinic. We do have a special immunization clinic in Nova Scotia as well. So as this is rolling out, and we do this with all vaccines, but of course, since this one is new, we're being extra diligent about making sure we use this pathway. This clinic is staffed with allergists and immunologists based right here in Nova Scotia. We're lucky to have a special immunization clinic. There are only 6 provinces in the country that have them. And ours is based at the Centre for Vaccinology here at the IWUK. What happens is if we get any sense that somebody may have had an allergic reaction in dose 1, for example, then it's straight to the special immunization clinic for dose 2, where it can be given under supervision. And then we figure out from there whether or not we need to consider it a true allergy. So that route has already been activated and is working well. All of this safety information is being tracked. This is from the Health Info base website for COVID-19 vaccine on the Government of Canada website. And so on a daily basis, they are updating the total doses administered, the number of adverse events we've seen as a result of that, which has not been high in Canada, and then the nature of the adverse event, how many were non-serious and how many were serious. So you can follow along with us if you like. That information is available on the Government of Canada website. I want to talk a little bit about herd immunity because this came up last time I spoke to you, and I just want to remind you of what that is and why vaccines and this vaccine will be important in that way. So the idea behind herd immunity is that you have a virus that's circulating somewhere in the community. When it comes along, it's looking for a host that it can infect, a host that is susceptible, so able to get the disease, as opposed to a host that is immune. Here you have 10 hosts who are all susceptible. And so what that means is the virus comes along, it finds the first host, it's able to infect that host, who can then replicate the virus, and now that host is infectious and they can infect somebody else. And on it goes. And some of these hosts might infect more than one person. They might infect 2, for example, and we've seen that with coronavirus. And so every chance the virus gets, basically, it's going to find somebody who's susceptible to infect, and that's how the outbreak keeps going. If you protect these same hosts with a vaccine, which is the red circle, then the virus may be circulating in community, but as it comes along, it can't go anywhere because it can infect that person because they're immune now. Even if it finds a susceptible person, somebody who's not immune, it has limits to where it can go because it's not long before that chain of transmission ends up with somebody who is immune, right? And so that's basically the concept behind herd immunity, is that the more avenues you shut off for transmission of the virus, the better. So the principle is basically that the more people there are who are immune, who can surround a person who is susceptible, the less likely it is that even the susceptible person will get infected. So if you take the same slide that I just had and now flip it around so that the virus is coming in from the left-hand corner, you can see that the first people it's going to meet are immune people, in which case, right off the bat, there's nowhere else for it to go. That doesn't mean that the virus is gone, though, is the thing. It may still be circulating in community, in some susceptible human hosts, or in the environment, or in animal hosts, depending on the virus. And so the concern is that you have to keep a level of immunity in the population in order to maintain that herd immunity effect. Otherwise, you give the virus a new window to get in and start transmitting again. But that's the idea behind vaccines. So the more immunized people there are in a herd, in a group, the better it is for the whole herd because the virus simply has less pathways to use. We did talk about this before, though, because I said to you at the time, and I'm going to repeat it again, herd immunity from catching the disease is not likely a plausible thing in the case of coronavirus, because the catch about that immunity, remember I said that the virus, even if you have a number of immune people and it's not transmitting frequently, it's not gone. If the immunity drops, which is likely to if you just had coronavirus but you didn't have a vaccine, If the immunity drops over time, then you've all of a sudden the virus has a wide open window again. And so our hope with the immunization is that that will be long lasting. We don't have the data on that yet. This is part of the post-marketing trials that we're doing right now. The post-marketing surveillance is to see how long will that immunity last. So far, we have about 3 months of data, which is a good sign. I'm crossing my fingers that it's going to be even longer than that. The whole point is that we need it to be long lasting. Otherwise, you have to keep re-immunizing the population in order to keep that herd immunity up. The same thing would be true if we tried to get herd immunity from catching the disease. You would have to keep catching the disease in order to stay immune to it, which would defeat the whole purpose, especially with a disease like this that is so dangerous. And I think at our last discussion, David pointed that out. You don't want to try getting immunity from getting the disease because the disease itself is lethal. And we have so much evidence for that already. So the risk of trying to get herd immunity would outweigh the benefits. The safer approach is simply to get immunity with vaccine, and that's the whole point of this effort. So I'm just going to turn briefly now to where we're at with the vaccine program, and then turn it over to Dr. Cookey. So this is what the National Advisory Committee on Immunizations rolled out in December, which was their sort of roadmap for the Canadian immunization strategy with these vaccines as they become available. And so I know it's small print, but I'm only going to point to a few things here. In these hexagons at the top, you'll see that the priority was basically to get to those who are at high risk of severe illness and deaths from COVID-19. That is the priority. That's the emergency that we're in right now. Second priority was to get to those who are likely to transmit COVID-19 to those at high risk, and that includes those who are essential to maintaining the COVID response. So all of those frontline doctors and nurses and personal support workers and the folks like Lisa who are working at Northwood, all of those folks are essential to the COVID response. And so that was always going to be a priority for us. And then there's a third category, which is contributing to the maintenance of the other essential services that we need in order to keep society going through this crazy time of quarantine and everything else that we're doing. And then the fourth is those whose living or working conditions put them at increased risk of COVID infection. And that's particularly in those living conditions are crowded. This would be our corrections facilities, our shelters, but it would also be some communities, Indigenous communities, and in some cases, African Nova Scotian communities as well. That was all part of the consideration. And so what the National Advisory Committee on Immunization proposed was, for now, let's concentrate on 2 stages. So a first stage that's basically now until March, and then a second stage that's basically March until 1st of July, and then we'll figure out after that where we go from there. And so what you're seeing us engage with now is that first stage where we're trying to get to residents and staff of long-term care facilities, older adults in community, healthcare workers, and there will be other communities as the months go on, and then focusing now on building our capacity for stage 2. But all of this is happening currently in a context of a lot is still unknown. So we still have only 2 products. Canada has signed on for 7. We don't know when the other 5 might be approved. All of the products are different. So the 2 mRNA vaccines that I spoke to now, in particular, what's interesting about them is that they require a particular storage capacity that we don't normally have to use for vaccines. So that's been a challenge, just getting that in place, let alone getting in place across the entire province. The amount of vaccine we're getting, remember when I spoke to in the fall, I said, as far as I knew, we would only be getting tiny amounts. Well, that has proven to be true. So up until last week, I think we had only received something like 9,550 doses of the vaccine for the entire province. I think this past week we were expected to receive approximately another 10,000. That's still a drop in the bucket for what we need, especially when you consider that it's 2 doses. So when I say those numbers, actually it's only half of them that we're using right now because the manufacturers have asked us to hang on to the second half to make sure we have it for the second dose. We're hoping that by the time this stage 1 is done, we will have gotten about 140,000 vaccines. That's still a tiny number. That still means 70,000 Nova Scotians that we can immunize. So not great numbers. But then by the time we're done with stage 2, we're hoping that we'll be closer in the order of about 1 million vaccines, and so able to pick up speed then. So we're actually flying this plane as we're building it. And The target is high. It's 75% of the eligible population because we are hoping that herd immunity is what's going to follow. And it's going to take us the majority of 2021 to get the vaccine out under the current circumstances. So I'm not going to spend a lot of time in this. This is basically sort of the phased program that I just described. But the idea is that once you become eligible, you stay eligible. So it's not like we're going to say at the end of phase one, healthcare workers, if you didn't come forward, too bad, so sad, you're not going to get any vaccine at this point. We're going to keep them in, but start adding others in so that the program is kind of picking up steam as we go. So that, as I said, by the time we get to that phase 2 of April to September, and hopefully have the 1 million doses that we're expecting, we'll be in a position to really kind of ramp up the volumes and keep up with those groups that we're going to add in. The nice thing about that is, I have to say, I know there's been a lot of criticism across the country around, how slow the vaccine program feels. We haven't had a lot of doses here in the province of Nova Scotia, so it may feel slow, but we're using the doses that we bring in. We're not bringing in a whole lot right now. We also don't have the pressure that the other provinces have in terms of the high number of cases that they have, and so they're trying something different because of their epidemiology. Remember, I said Nova Scotia is in a good place because of what we've done so far. The other provinces don't have that sort of backstop for their COVID response. So they are in this pressured place of having to get vaccine out, I think, much more rapidly, and actually having to get all of the doses out, not holding back that second dose, which puts them in a little bit of a vulnerable situation on a number of fronts. We don't have that pressure. And so some of what we're able to do here, which is interesting to me, having gone through this same exercise during H1N1, it's a very different approach that we're using here, which is actually using each of these phases that I just described. While we're not getting lots of vaccine anyway, now is the time for us to take what we have and be creative about, so what are the ways that we could deliver this that would actually get to the right people in time, in a way that's accessible to them, all of those things. And so there's an entire team at Nova Scotia Health Authority and Department of Health and Wellness who are devoted to only answering that question and basically no other question. And it includes people from Department of National Defense, as well as people from the Health Authority and from provincial government. And I think it's a really interesting way for us to use the advantage that we have of time and space and not a crush of cases, to see if we can actually be in a position that when we get those 1 million, we're ready to go because we figured out 5 ways of getting vaccine to people instead of one model only, which is mass immunization clinics, which you'll remember from H1N1 weren't particularly accessible. So some of that thinking is happening behind the scenes right now, which I think if we're going to do that, now is the time to do it. Lots of unknowns in that. I'm not going to spend a lot more time on that. Again, it continues to evolve with every day, and of course all kinds of ethics questions to wrestle with within that. That's in keeping with what we see anytime we get into sort of a mass immunization effort like this one. But we do have this advantage of our low epidemiology, which I'm quite grateful for. And so here's the bottom line from my perspective. We are going to continue to need to be vigilant for new COVID cases. Having the vaccine right now, it is a good news story, but it's too soon to tell how long that good news will hold. So for the time being, we need to keep doing all the other things we were doing, and now add in vaccination as part of the COVID response. This is a historic effort. So I'm really, it's exciting to be part of it. I'm excited for Lisa to have had the big role in it that she's had as the first African Nova Scotian to receive two doses. And so I'm hopeful for where we are, and just very pleased that we're here as early as we are. I think 2021 looks good from where I'm sitting based on this knowledge. Just a reminder that flu is also an additional threat that we want to avoid. We don't want to add that to COVID. So if you haven't got your flu shot, please get it. But in the meantime, it's the same message: wash your hands, wear your mask, keep your distance, get vaccinated now, or not now, but when it's available, and stay safe and download the COVID app. So that's it from me. And I think
Thank you, Dr. Gaynor. That was great. And Jacob is there somewhere. He's up next, please. Thank you. Can you introduce yourself, Jacob, and go. Thought I saw him there.
Hello, can you hear me? All right,
Yeah, we can.
right on. So yeah, I'm Jacob Cookey. I'm a community mental health psychiatrist at Cole Harbor Community Mental Health Clinic. Also a board member of HAAC, and also work with the Nova Scotia Brotherhood Initiative. I was asked just to make a couple comments on the mental health angle of this. I'll be very quick because I don't have a whole lot to say that hadn't already been said, but happy to answer questions in the end. And I think the discussion, which is already, I can see it hot in the chat already, will be the most valuable and interesting, I think, for us. So I'll just say a couple quick things. As you know, COVID-19 has hit us all hard, but it's been especially hard mentally on a lot of people. We see it in the clinic quite a bit, and it's especially hard on the folks that we work with who live with mental disorders. Especially we've been seeing an increase in hospital admissions, which has been really tough for us to cope with in the hospital and also in the community. I won't say more about that, but if there's questions, we can discuss in more detail. But the bug itself also, in terms of those who are living with mental disorders, hits that group harder than the general population, similar to the Black community, for a number of reasons. And there's also a significant amount of mistrust in those with mental disorders for the same reasons. I won't rehash them, but Dr. Haase did a really good job of outlining some of the history of how the medical community approaches different subgroups and minority groups. So just to put voice to that, on behalf of those that we serve, that, that we're aware of that and that we're advocating strongly for that group. And also hopefully we can also make it more accessible, because a lot of folks, again, will be avoiding getting it for a variety of reasons. A quick word on the conspiracies that you may or may not be aware of, especially the big Bill Gates conspiracy, probably the most prevalent one. I was surprised to learn that 10% of Canadians believe that Bill Gates has made this vaccine to implant microchips in us. 30% of young people believe that in Canada. So it's I thought it was, that nobody would actually believe it, but far more prevalent than I thought. And I've heard just from a lot of other friends, colleagues, people in the community, a lot of other ideas about it. Happy to discuss that as well if there's questions about that. But what I would say is, all of these things, they feed on our fear and our distrust. All of these conspiracies, and I would just ask that you kind of, if you're honest with yourself, and consider, the actual likelihood of any of these things actually happening, and then compare that to the possibility, the probability that there actually is a virus and there actually is a vaccine with good efficacy against the virus that can protect your life and your loved ones' lives. So I would just leave it at that, but something that I think you've probably come across a lot of it already, but is worth mentioning. I would echo what Lisa Colley said. I think that was amazing what she was speaking about earlier, and I think it's far better to err on the side of safety and get the vaccine compared to testing the waters with potentially getting the real virus. I don't know the full numbers in terms of if there has been and how many have died from the vaccine. I haven't heard of any, and I think it's extremely low, but I do know it's, about a 1 in 100, 1 in 200 chance of death from the real virus. So for me, I'll take the vaccine any day against those odds. So just to keep in mind that we should consider what's more likely happening and kind of act accordingly. And so the last thing I'll say is, I think also Lisa mentioned this, that we all love getting out, barbecues, weddings, parties, community, church. It's been a long time since we could do that freely. And the one other aspect of the vaccine is the faster we can hit that herd immunity, the faster we can get back to living our lives the way we love to. So I'll end there. I won't say much more, but I'm happy to talk more, make more comments if anybody has questions from the mental health angle. Thank you.
All right. Well, all right. First of all, I just want to thank so much our presenters this evening. I want to thank, please do show your love, send up those hands. Thank you, thank you, thank you to Dr. David, to Dr. Gaynor, to Dr. Jacob. We are so fortunate. They are of us, from us, and with us, and this is wonderful. We've had a great opportunity to hear a lot of good information, and I know there are a ton of questions. And Veronica, you and I think, have been looking at some of these questions, but the first thing I want to do, because Dr. Jacob has just finished, one of the questions was around how do we keep mentally well? What would you recommend keeping mentally resilient with the anxiety that comes with fear about vaccines? So if you could just start us off with that, then I'll hand it over to Veronica to ask some of the questions that were in the chat. Dr. Jacob. Dr. Jacob. Okay. Well, maybe we better come. Oh, okay. I see him. I don't know if he hears that question. Did you hear that question? Unmute. Can't unmute.
All right, now I've been given permission.
Okay.
Yeah, how do people? So yeah, we've had a couple of talks on it, but I always go back to the same refrain because it's going to be different for everybody. Such unique circumstances. Some living in a house with 10 people in it, others living alone. Some people in their early 20s or 30s, others in their 80s and 90s, and so on. So I would say the core things that keep us well mentally are the same core things that keep us well physically. It's we speak about mental illness as if it's a different beast, but it's a false dichotomy between mental health and physical health. It's the mind, the brain arises from the brain, and so anything that's good for the brain is good for your mental health. And so we always say the big three things are trying to make sure that you're eating regularly, so feeding the body, feeding the brain, trying to make sure that you sleep regularly and well. It's easy to get thrown off of our daily, the so-called circadian rhythm, being stuck in the house all day and not doing much and in front of a bright screen. So forcing yourself almost to turn the screen off, take a break from things, and allow yourself to get a good 8-hour sleep is very important. And then moving in any way, So winter being no excuse. If you're inside and you have the ability to move any limb of your body, to find some way, whether it's dancing to music, doing yoga, just walks. I know some people who literally just pace around their house and that's their exercise. But if we don't move, we really start to notice a decline physically and then mentally usually. So it's amazing the power of more and more that we're finding out in the science now reflects this, the power of exercise in reversing things like depression and anxiety. There's a few landmark studies the past few years where simply that was tried against other interventions, psychotherapy, medications, placebo, and it's right up there in terms of the effects of purely exercising. So it's hard to overstate the importance of those three things: eating, sleeping, and moving. So I'll leave it there.
Thank you so much, Dr. Jacob. All right, over to you, Co.
Thanks. Thank you, Dr. Jacob, for that. We just want to remind folks as well that if they are struggling with some anxiety, that the toll-free line is still available, that we can connect you, make a referral to a clinician to assist you. So please feel free. We'll put the toll-free number in the chat so folks can utilize that service that we have available for you. So we do have a number of questions. I see Dr. Gaynor has been busy responding to some of them in the chat already, but just going through them, I kind of pulled out, and thank you, Jacob, for providing a list of the ingredients that are in the vaccine. So that's already been addressed. Natalie had asked that question. So I believe as well, Dr. Gaynor, you already responded to Elizabeth Cook-Sambu's question of how long the vaccine will last in our body. You as well addressed the question of how do these ingredients react. This was in your presentation, to medication for anxiety and depression. Archie wanted to know if if we'll need to be vaccinated each year. Is it like getting the flu vaccine? Dr. Gaynor, was that responded to in chat? I'm trying to keep up with all of them.
I did. I think that was the last one I responded to, and then I lost track. So the answer to that one is we don't know yet. So our hope is that this will give us long-term immunity, and that it'll give us immunity that will stay ahead of the mutations that I know some folks are asking about in the chat as well. But that's all part of that post-marketing phase right now. It's possible that we will need to do this on a yearly basis as we do for flu, and folks will remember for H1N1, what happened there was that we did it for H1N1 that year, and then we made it part of the regular flu vaccine going forward. So we did have to do it even for H1N1 every year. We don't have COVID vaccines right now that we give every year, but it's possible that that could be something that that we do going forward. So it's still a little bit early to tell, but my hope is that we're going to see long-lasting immunity from this vaccine.
Okay. Another question that was asked, will there be vaccine clinics within the African Nova Scotian communities like we had in the Preston Townships, and will the community healthcare practitioners be used to provide those vaccines?
Yeah, my answer is I would hope so, and I think anything is on the table right now. It's not something that I would suggest that the health authority or Department of Health and Wellness jump into without having a conversation with the right folks in the Black community about how best to do that, how to recruit the right people, what the feel of the clinic is. All of that I think is up for grabs. So it's a matter of making the connection, but I think it's absolutely on the table. I don't know why it wouldn't be from my perspective. So yeah.
Okay. All right, that's good to hear. Andrew, yes, this presentation, Carla has been very diligent having it recorded, and will be posted on our HAAC website, so you can go back and refer to it, and we'll also get the summary of the questions as well.
It'll be posted on our Facebook page, sorry.
Facebook, okay.
Yep.
Okay.
And also on the Black Cultural Center website and YouTube.
Thank you both. Okay, there have been cases, Ashton has noted that there's been cases of persons who have been reinfected with COVID-19. What does this fact suggest about the prospect of the vaccine conferring long-term immunity? Were the trials done on Black folks with underlying health conditions?
So let me answer the second question first. Yes, Black people with underlying health conditions were part of the trials that went forward, which is important. In terms of reinfection, it's another one of those things that we don't know the answer to yet, even around whether or not the reinfections that we have seen constituted truly reinfection. That's still being investigated worldwide. And so we're not certain that that's what we're seeing with this. If we are seeing reinfection, true reinfection, then I think it makes a stronger case for getting immunity through vaccine because, as I said earlier, getting the disease is dangerous. It does carry a higher mortality rate than we would want to see for a respiratory disease like this one. Getting the vaccine would be a way of getting immunity without having to get the disease. So I think reinfection suggests that it means that getting immunity from disease is not long lasting enough to protect you from not being able to get the disease again, which we don't want. And B, it means that folks are not, because they're not protected, there's a need for that longer term protection that a vaccine could provide. So I think actually if we're seeing reinfection, it's a stronger argument for having the vaccine.
Okay, thank you. This is a good point, Shelley. Shelley has asked, do we know which of the vaccines that we will be acquiring? So you mentioned the two that are being out there. Do we know, do we get a sample of both, or how does that work?
Yeah, so we have both in the province right now, the Pfizer vaccine and the Moderna vaccine, and we have ongoing contracts to keep rolling those in. As we get new products approved in Canada, we'll be adding those into the mix. So I don't know how many we'll have, say by next spring, how many different vaccines we'll have. But that's not uncommon. Like even our normal childhood immunizations, for example, those childhood immunizations come from a number of different manufacturers, and we always have a mix of products. And it's an assurance mechanism of making sure that we don't rely only on one supplier, only to have that supplier completely dry up on us, and then we have a vaccine shortage. So by having multiple suppliers in the mix, you avoid that. Interestingly, we did not do that for H1N1, and I don't know if folks remember the significant consternation that created when we ran out of vaccine during our H1N1 immunization campaign. That was why the federal government had not gone to multiple suppliers. So we've actually learned from that lesson. That's why we have multiple suppliers this time around. What we can't do with these vaccines yet, which we can sometimes do with our childhood vaccines, is mix between manufacturers. So if you got your first dose is Moderna, your second dose needs to be Moderna for the time being. As we learn more about these vaccines, we might get more comfortable switching it out with Pfizer if Pfizer is all that we have available at the time. So what it means right now is if you got Pfizer, you get Pfizer for second one. If you got Moderna, you get Moderna for second one. That's really it in terms of the approach to the different products.
Okay, so I've gone through the list of questions that I was able to pull out. Sharon, do you?
There was one that Deacon Rose wanted to know about. What is the rate of allergic reactions? Dr. Gaynor, maybe, or?
Yeah, so far worldwide, it's being reported as, I think it's 11 per million, something like that. So 11 cases out of every million of the vaccine might have an allergic reaction. Again, it's early days, so time will tell, but that's a relatively low rate of reaction to this vaccine. So we'll see what happens as we roll it out.
And I thank you. And I think there were a lot of questions about the reaction of the vaccine with drugs that people were taking. You may have already said this, but there were a number of them. You know, what if I'm taking this drug? What is the interaction with others? So generally speaking, I think I heard you say that it's you know, you do the math. If this is going to be beneficial to you, more beneficial to you, then you take the vaccine. I don't want to put words in your mouth, Dr. Gaynor, you tell us.
Yeah, now let me just clarify that one because I think it's an important one. So there's a difference between taking a drug and having a condition that you might be taking a drug for that puts you at high risk for COVID or high risk of reaction to the vaccine. So far, we don't think that there are many conditions other than an allergic reaction to PEG that will put you at high risk from the vaccine. Any other chronic condition you have, if it's an autoimmune condition, for example, or a immunocompromised condition, we would mostly be worried that you might not respond well enough to the vaccine when you get it. And particularly for immunocompromised persons, that's the concern. In those cases, though, I have to say that the concern works both ways. That means that if you can't respond well to the vaccine, you're not going to be able to respond well enough to fight off natural infection either. And so in those cases, often we would say to folks, you might be better off just getting the vaccine because we don't want you to get infected. Some people will have conditions that they're taking drugs for which make them immune compromised. Those would be the drugs that we would be worried about. But all other drugs that folks might be taking for type 2 diabetes or for hypertension or for anxiety or for other chronic conditions, those are not a risk for the vaccine because they don't interact with the vaccine. We are suggesting that folks delay getting other vaccines or delay getting the COVID vaccine if they've recently had, in particular, a live vaccine. There's not good evidence that there's particular cross-reactivity between those groups of vaccines, but if we allow a lag time between when you got one vaccine, let's say you had to get a measles vaccine for some reason, and then you are due for your COVID vaccine, if we allow some lag time, then we know that when you get a reaction like that chills and fever from the COVID vaccine, that it's from that and not from the measles vaccine. So there are some things like that that we get into when we're talking about administering different vaccines alongside COVID. But aside from that and immune compromising drugs, there's really no interactions that we're concerned about at this time.
And of course, if people are in doubt, we have all kinds of good health professionals to ask questions about if we're concerned or we have a question that hasn't been answered in our town hall or the next one. So it is 7:57. And just look at how time has flown. I just want to again thank everyone who has been online with us. This has been so tremendous. We've never had this kind of response. Let's hope we keep getting it. And someone has said, consult your family doctor if you have doubts. That's the most important thing. So ask the questions and get the answers. So Veronica, over to you.
Just before we leave, we would love to have an opportunity to have a snapshot. We've never been able to capture everybody on our town halls, and we probably won't be able to get everyone. But if we could ask people to turn on their camera so we can do a picture if you wish. If not, that's fine. But just so that we can have a snapshot of you beautiful folks.
If you let me do 4 screenshots, I can get everybody.
Okay.
All right.
Get them all, Carla, but it would be awesome.
All right, give me a second.
Beautifully. Show up.
Great.
Were you going to get vaccinated?
I will definitely, as soon as those vaccines are available.
Can I just do my?
I think Marsha asked a great question. In a province, Dr. Gaynor, where we have a large percentage of aged folks, why are we not getting a larger dosage amount?
Yeah, I wasn't part of all of those conversations about the allocation nationally. It was meant to be per capita, but I haven't looked at the math myself. I just haven't had a chance to see sort of how that shook out and how that was done. So I think it was more per capita generally and not per capita, for example, by COVID risk factor, which might have been the way to address that question. So it is what it is, but again, given where we're at with our epidemiology, I'm happy that we have enough vaccine to start the ball rolling and not facing what the Western provinces are facing.
Right.
Veronica,
yes.
May I just put up one more poll question before we go?
Long as you're going to say a sweet goodbye after.
Let me just put up this one question. So we're going to go back to that website, menti.com.
Yeah.
I don't know if you close it, but if you did, just quickly go to that menti.com and use that code. And here's a question. I wanted to rate your level of agreement before and after the town hall. So there are the two questions. Before the town hall, were you comfortable taking the vaccine? And there's a rating scale from strongly disagree to strongly agree. And then after the town hall, what difference? And then I'm going to open the voting and start the clock. I'm going to give you a little bit of extra time because I know not everybody has voted.
Somebody's raised their hand, David.
Huh?
Somebody's raised their hand.
I can't see with my sharing screen. What's the question? Can you ask a question? Somebody have a question?
Someone wants to know about the vaccine effects on fertility.
Oh, okay. All right. So, all right,
Lots
we'll
of questions.
close the poll then.
It looks
Alrighty.
like more people are comfortable, doesn't it?
It looks like a bit more people are comfortable now than
Yeah.
before.
Well, that's great.
A bit more
Okay.
comfortable, yeah.
All righty. We're done.
All right.
Thank you.
So let's take 2 seconds for Dr. Gaynor to talk about fertility, and then we are going to be fertilely saying goodbye.
After the snapshot, did you get the picture, Carla?
Carla, are you able to take some photos?
I think she did.
Snaps? Okay. All
Perfect.
right.
So the fertility question, we don't find the vaccine on pregnant and look at the vaccine. And what I didn't say, the Center for Vaccinology here in Halifax, and especially, we actually have some of the country's leading experts on vaccinology and immunology right here in Halifax. So we've pulled them all into a working group. In the conversations we've had with them, what they've indicated to us is that there's, for at least the 2 vaccines we have right now, these mRNA vaccines, there's no particular reason why there should be an impact on fertility. The manufacturers are really cautious about this type of thing. And so when they put something like this out and they haven't done the studies directly in those populations, they always put out these cautionary statements that say, don't use the vaccine or be careful about using the vaccine in these groups. There may not be any good reason for that. And so we'll continue to watch it. And I think as we go forward, you will see the manufacturers now bring pregnant women into the trial so they can begin under controlled conditions to answer those questions. So we'll get more data. So the short answer is no reason with these particular mRNA vaccines that would be the case. But again, it's that risk-benefit conversation at the time around what you're ultimately comfortable with. And currently the NACI statement is not pointing to fertility. Of all the things they're pointing to, they're not pointing to fertility as a particular risk.
So sister, thank you so much, Dr. Gaynor. Sister Rhonda wants to make sure we get all those questions. And indeed, we did ask people to, if their questions weren't answered, to please go and pose them to our HAAC website. We will be answering them on our website, and we will make every effort to make sure that all of those questions are answered and that you have the information that you need. It has been such a terrific time with you all this evening. And I want to say thank you for being here. I want to tell you that I'm among those who definitely want this vaccine as soon as it's available. I want our people protected. And to me, it just makes good sense. I will pass it over to my to say a sweet goodbye.
just thank you all for being here. Thank you all for, thank you to the presenters for the
Yes.
information that they provided. Very informative, very educational. Please, folks, stay safe. Not only you, but your family members and your loved ones. Thank you so much for sharing your time with us this evening.
Thank you and goodbye, everybody.
And I did get the screenshots. I was talking away, but I was on mute.
Okay. All right.
All righty. Thank
Good
you
night,
both.
everyone.
Thank you, Carla. Thank
night,
you, everybody.
Thank you,
and good
everyone.
night.
Thank you.
Take
Thank you
care.
all.
Thank you,
All
Russell.
righty.
Thanks, everyone. Great job.